Hi everyone. So today we're going to be going over caring for clients with diabetes. Diabetes mellitus is a metabolic disorder of the pancreas, which affects carbohydrate, fat, and protein metabolism. And this disease, as we all know, reaches epidemic proportions in the United States. So this is something that we're going to see relatively commonly in the nursing field. It's one of the consequences of metabolic syndrome, which includes obesity, especially in the abdominal area, high blood pressure, elevated triglycerides, low density lipoproteins, blood glucose levels, and a low high density lipoprotein level. So today we're going to define and describe glucose regulation, notice the risk factors for impaired glucose regulation, recognize when an individual has compromised glucose regulation, provide appropriate nursing and collaborative interventions to optimize glucose regulation, define and distinguish the two types of diabetes mellitus, identify the three classic symptoms of diabetes mellitus. Name 3 laboratory methods used to diagnose diabetes mellitus. Describe the methods used to treat diabetes mellitus. Identify categories of medications used to manage diabetes mellitus and their mechanism of action. Discuss the nursing management of the client with diabetes mellitus. Explain the source of ketones and cause of diabetic ketoacidosis. List 3 main goals in the treatment of diabetic ketoacidosis. Identify 2 physiological signs of hyperosmolar hyperglycemic non-ketoic syndrome. Describe the treatment of hyperosmolar hyperglycemic non-ketoic syndrome. Explain the cause and treatment of hypoglycemia, differentiate between the symptoms of hypoglycemia and hyperglycemia, and describe common chronic complications of diabetes mellitus. So, glucose is fundamental to the process of human life. It is the preferred energy source for most cells in the body, and the neurologic system is dependent on glucose for energy needs. Now, when glucose metabolism becomes impaired, serious health consequences occur. Because this concept represents a foundational basis of health, the nurse must possess a solid understanding of energy and glucose regulation, including the ability to recognize and respond to situations in which this process is impaired. Now, glucose regulation is achieved through a delicate balance between nutrient intake, hormonal signaling, and glucose uptake by the cell. Once glucose enters the cell, it is oxidized through cellular respiration into adenosine triphosphate, ATP. The efficiency of glucose metabolism is reflected in circulating blood glucose levels. So for the purpose of this concept, glucose regulation is defined as the process of maintaining optimal blood glucose levels. We also need to know that glycogen is the major form of stored glucose, primarily in the liver and the muscle cells. Glycogenolysis refers to the breakdown of glycogen to glucose. Gluconeogenesis refers to the process of producing glucose from non-carbohydrate sources such as proteins and fats. So the scope of glucose regulation can conceptually be represented by the categories of normal, optimal regulation, and impaired regulation throughout the lifespan. Normal blood glucose levels range between 70 to 99 in the fasting state, and 100 to 140 in the 2-hour after eating, otherwise known as euglycemia. Impaired regulation can be further categorized and reflected in abnormally high or low blood glucose levels. Hyperglycemia refers to elevated blood glucose levels greater than 100 in the fasting state or greater than 140 2 hours after eating. Hypoglycemia refers to a state of insufficient or low blood glucose levels defined as less than 70. Some signs and symptoms of hypoglycemia is reduced cognition, tremors, diaphoresis, weakness, hunger, headache, irritability, and seizure. Some of the symptoms for hyperglycemia are polyuria, polydipsia, dehydration, fatigue, fruity odor to breath, Kussmaul breathing, weight loss, hunger, and poor wound healing. So hypoglycemia is a state of low glucose levels and will typically occur as a result of insufficient nutritional intake, adverse reaction to medications, excessive exercise, and or as a consequence of disease states. Often hypoglycemia occurs due to a combination of these factors. Hyperglycemia occurs as a result of insufficient insulin production or secretion, excessive counter-regulatory hormone secretion, or from deficient hormone signaling. The word diabetes means sweet urine, and the term diabetes mellitus is used to describe a group of disorders characterized by chronic hyperglycemia and disturbances in carbohydrate, protein, and fat metabolism. Impaired glucose regulation can potentially occur in any individual regardless of age, race, cultural identity, or gender. However, there are well-known risk factors for impaired glucose regulation. So some populations that are at risk are pregnant women, infants, older adults, and certain racial and ethnic groups. So those that are pregnant, because pregnancy is associated with hormonal changes, it produces a state of insulin resistance and associated risk for hyperglycemia. So all pregnant women are actually screened for gestational diabetes during the 24 to 28 week gestational mark. For infants, the large for gestational age infant is at high risk for hypoglycemia after birth. The prevalence of neonatal hypoglycemia is also higher among infants whose mothers had diabetes during pregnancy. In older adults, they are at a greater risk for impaired glucose metabolism and hyperglycemia because of an increase in visceral fat and associated reduction in lean muscle mass, where most glucose is metabolized. For certain racial and ethnic populations, there are genetic predispositions to insulin resistance, leading to a higher risk for type 2 diabetes, especially American Indians, Alaska Natives, African Americans, Hispanic Latino, and Asian Americans, compared to a very smaller percentage among those that are white. There is a growing trend of increased diabetes prevalence seen in societies that become more modernized, affluent, and westernized, and thus increasingly sedentary, as seen in China. Some individual risk factors are genetic risk factors, lifestyle risk factors, chronic conditions, and medications. So some genetic risk factors, there are about 40 known genetic markers, including HLA genes, associated with the risk of diabetes. Some lifestyle choices promote and worsen insulin resistance. So one of these is a poor diet with a high intake of saturated and trans fatty acids and a low fiber intake. Also, an inappropriately high intake of calories, particularly carbohydrates, will also adversely impact glucose metabolism, regardless of the presence of insulin resistance or type 2 diabetes. Some chronic conditions can mess with glucose regulation. Diabetes and metabolic syndrome are the most notable, but medical conditions interfere with oral intake, creating the need for enteral or parenteral nutrition, and this can impact glucose regulation. malabsorption, and nutrition deficiencies required for cellular metabolism of glucose, including vitamin D deficiency, contribute to insulin resistance and are related to suppressed insulin production. Some medications that contribute as a risk factor because they can affect glucose regulation, which can place an individual at risk for hyperglycemia or hypoglycemia. The most common are insulin, oral hypoglycemic agents, corticosteroids, estrogen, ACE inhibitors, beta blockers, potassium depleting diuretics, bronchodilators, antipsychotics, and many antibiotics. A number of significant physiological consequences are associated with poor glucose regulation. So, hyperglycemia and insulin resistance are known to be toxic and pro-inflammatory, which causes cellular changes, cell death, and contributes to the various long-term health. Likewise, hypoglycemia can result in impaired function of the neurological system and be of great danger to the patient. So, in a healthy individual, glucose regulation occurs with little awareness given to the process. And to help maintain glucose homeostasis, there's a variety of hormones that are required. Now, insulin is the only hormone produced that lowers elevated blood glucose levels after carbohydrate intake. There are several counter-regulatory hormones, which are hormones that oppose the action of other hormones and that are required to raise blood glucose if levels begin to decrease or in anticipation of increased needs. When the system works the way that it's supposed to, the glucose levels will remain normal, even in the setting of extreme stress. Now, after the consumption of food, insulin is released in response to rising glucose levels. Insulin facilitates glucose metabolism by binding to insulin receptors on the cell wall, signaling glucose transporter molecules that facilitate glucose entry into the cell. Insulin suppresses glucagon secretion and facilitates glycogen storage. Glucagon is one of several counter-regulatory hormones released in response to cellular deficiency of glucose. So, glucagon will suppress insulin and stimulate the hepatic glucose production, resulting in elevated glucose levels. And gluconeogenesis is required if blood glucose and glycogen stores are insufficient and can also occur with stress conditions or from use of steroid medications, with resulting increased risk of loss of muscle mass. Some other counter-regulatory hormones released include cortisol, growth hormone, norepinephrine, and epinephrine. So the counter-regulatory hormones all lead to utilization of glycogen stores, and these hormones are also increased with stress-related conditions, both physical and emotional. And so they're often referred to as stress hormones. So when we're talking about problems with glucose regulation, we either have too much glucose or insufficient glucose, right? So when we have too much glucose, it's because of insufficient insulin production or secretion, excessive counter-regulatory hormones, or from deficient hormone signaling. So when we're talking about insufficient insulin production, insulin is produced, stored, and released by pancreatic beta cells, and damage or destruction of the beta cells results in insufficient or a complete stop of insulin secretion. And if we have insufficient insulin secretion, this results in a hyperglycemic state because the glucose is unable to enter the cells for cellular metabolism. So damage to the beta cells is usually caused by an autoimmune response with a genetic disposition, or can occur as a secondary mechanism from other diseases such as pancreatitis or pancreatic cancer. So in deficient hormone signaling, the term insulin resistance refers to a state in which the body cells respond abnormally to the signaling action of insulin. Basically, there's not a problem with insulin supply, but rather with how the cell responds to insulin signaling due to a reduction of insulin receptors or glucose transporter molecules. And so what will happen is you'll get these sluggish glucose uptake by the cell. So the pancreas overproduces insulin to compensate for reduced cellular glucose uptake, resulting in hyperinsulinemia. And when insulin resistance persists for long periods of time, the insulin producing capacity of the pancreas is exhausted, and then hyperglycemia ensues. Last but not least, if we have excessive secretion of any of the counter-regulatory hormones, this can result in hyperglycemia. These include glucagon and cortisol, a hormone that raises blood glucose through gluconeogenesis. And causes of increased cortisol secretion include chronic stress, pain, sleep deprivation, and acute injury or illness. It can also occur as an adverse effect of medications or due to Cushing's disease. We also have to remember that insulin resistance is understood to be a pro-inflammatory state, so it contributes to atherogenesis and plaque formation, and is thought to be associated with increased cancer risk, with hyperinsulinemia appearing to act as a cellular growth factor. Reduced cancer risk has been noted among people who take insulin sensitizing agents, such as metformin. Hypertension is present in about 50% of insulin-resistant individuals and 80% of those with type 2 diabetes, both sharing a common mechanism of high oxidative stress and inflammation. Hyperinsulinemia causes hypertension through its role in reducing elasticity of blood vessels, and reinforcing this influence on hypertension is the recognition that reducing carb intake can lower blood pressure levels. So some of the consequences of hyperglycemia can be angiopathy, and this is damage to the blood vessels. Also peripheral neuropathy, which is nerve damage. And peripheral neuropathy causes symptoms such as like burning and numbness in the lower extremities. And also it can cause fluid and electrolyte and acid-base imbalances. So when somebody's dehydrated, impaired mental status, things like that. So hypoglycemia is a state of low glucose levels and will typically occur as a result of insufficient nutritional intake, adverse reaction to medications, excessive exercise, and or a consequence of disease states. So when we're talking about insufficient nutritional intake, basically, malnutrition leads to depletion of glucose stores in the liver and adipose tissue and will prevent the liver to maintain normal glucose levels. The free fatty acids are then mobilized as substrates for glucose production and will result in the production of ketone bodies. Prolonged starvation and malnutrition can eventually lead to life-threatening hypoglycemia. When we're talking about adverse reaction to medication, hypoglycemia is generally attributed to inappropriate dosing of exogenous insulin or the sulfonylurea form of oral hypoglycemic agents, which increases endogenous insulin production. So once an individual requires insulin therapy to maintain glucose control, creating a physiological insulin replacement regimen while avoiding hypoglycemia can be difficult and is one of the great challenges of caring for patients with diabetes. In excessive exercise, the work of muscle contraction requires energy, and initially this energy is derived from glucose stored in muscle cells such as glycogen. As an exercise interval lengthens, glucose stores are quickly depleted, and then glucose from the circulation and hepatic glucose stores are utilized for energy, which then will lower your blood glucose levels. During post-exercise recovery, muscle cells then replenish glycogen stores with additional glucose from the circulation, also lowering glucose levels, and this is sometimes referred to as the lag effect. So some of the physiological consequences of hypoglycemia: the impact of the body's processes to contend with and overcome adverse effects of inadequate glucose availability is mostly unknown. Because the brain depends on glucose as its only source of fuel, hypoglycemia can progress from mild symptoms of nervousness, irritability, diaphoresis, anxiety, and palpitations to neurological changes, seizures, loss of consciousness, and death. Recurrent hypoglycemia can lower the blood glucose level that typically stimulates counter-regulatory hormones, and so symptoms of hypoglycemia don't occur until glucose levels are dangerously low. And frequent hypoglycemia is associated with a 3 or 4-fold increased risk of death and a higher risk of chronic cognitive impairment and accelerated cognitive decline. So chronic hypoglycemia leads to the condition of hypoglycemia unawareness, in which the counter-regulatory hormonal response is blunted, describing a state of autonomic failure. This includes diabetic neuropathy and other symptoms of gastroparesis with associated symptoms of early satiety, so they're getting full too soon, poor food absorption, constipation, fecal incontinence, and diarrhea. The spectrum of autonomic neuropathy includes impaired pupil response to light, erectile dysfunction, loss of vaginal lubrication, painless cardiac ischemia, impaired exercise tolerance, orthostatic hypotension, resting tachycardia, dry skin, and impaired temperature regulation. So when we are assessing, we are looking at their history. And the history includes personal medical history, including a list of their current medications, social history, family history, and a review of symptoms. In each of these areas, we want to consider data consistent with actual or potential problems with glucose regulation. Central obesity and diabetes are two clear conditions to note when noting down personal or family history. Again, we've talked about how certain medications can also place a person at greater risk for impaired glucose regulation, so we need to keep an eye on their medication. We also need to recognize common clinical manifestations of impaired glucose regulations, because a person may or may not have symptoms of hyperglycemia. Those that are in ketoacidosis may display polyphagia, which is excess hunger, which may occur due to cells not receiving adequate glucose. They might have polydipsia, which is excessive thirst, and consequent polyuria, which is excessive urination due to an osmotic diuresis, where the renal glucose threshold of 180 is exceeded and water is then pulled along with it. Some other symptoms to ask about in history include complications associated with long-standing hyperglycemia. Those with retinopathy might describe reduced vision. Somebody with peripheral neuropathy may report reduced sensation, or kind of like a pins and needles sensation in their lower extremity. You might see wounds that are not healing, or generalized pain that might be suggestive of poor peripheral perfusion. We want to establish that individuals with diabetes are at higher risk for developing depression, and so we also need to screen for depressive symptoms as well. So we need to look for a lack of interest, feelings of sadness or worthlessness, difficulty with sleep, appetite or weight changes, suicidal thoughts, and difficulty concentrating. So as we examinate them, we're going to want to include vital signs and measurements such as height and weight to determine their BMI, their body mass index, and waist-hip measurements so we can determine their waist-to-hip ratio. These measurements assess for hypertension and determine overweight or obesity, as well as central obesity. Obesity and central obesity are both associated with insulin-resistant states. So several physical findings that are common in those with long-standing states of impaired glucose metabolism is acanthosis nigricans, which is a velvety darkening of the skin that is sometimes seen on the posterior neck, axillate, and skin folds of the groin, a cutaneous marker of insulin resistance, and a red flag for diabetes risk. So if you look on page 138 of your concepts book on figure 15.2, you can see this, like, it looks like a darker part of in the skin fold. You should also look at your lower extremities and examine for evidence of peripheral vascular disease. Essentially what's happening is poor perfusion and chronic wounds. A foot exam includes inspection of a skin for blisters, ulcers, skin lesions, nail abnormalities, and excessive callousing. Sensation and motor strength of the extremities should be assessed to evaluate for neuropathy and assess visual acuity and inspection of intraocular structures that can provide important information with retinopathy, although a dilated eye exam provides a more detailed retinal exam. Diagnostic testing is an essential component associated with assessment for impairments in glucose regulation and metabolism. So, lab tests can help reveal the etiology of impaired glucose metabolism, measure and assess blood glucose management, and evaluate the consequences of impaired glucose metabolism on other disease conditions. So some of the things we could do is blood glucose testing, antibody testing, lipid analysis, renal function tests, and C-reactive protein. So in blood glucose testing, measurement of blood glucose is used widely for screening and monitoring glucose metabolism. A fasting glucose level greater than 100 and less than 126 is indicative of prediabetes or impaired fasting glucose. A level of 126 or greater on two separate occasions is indicative of diabetes, and a random blood glucose measurement greater than 200 with signs and symptoms of diabetes is conclusive. The glucose tolerance test is the most sensitive measure of glucose metabolism and can often detect early diabetes. The glycosylated hemoglobin, also known as HbA1c, is a lab measurement reflecting the average blood glucose reading and estimates glucose control for the prior 3 months. HbA1c is used for diagnostic screening and monitoring disease management, and a reading of 6.5% or greater is indicative of diabetes and can be obtained if the patient has not been fasting. So for antibody testing, the assessment of antibodies is used to confirm type 1 diabetes. And the most common test is the glutamic acid decarboxylase antibody test. A C-peptide test, which is an indirect measure of insulin levels, and fasting insulin level may be measured to help determine the quantity of residual insulin production. Lipid analysis is the most common lipid assessment and includes measurements of total cholesterol, high-density lipoprotein, triglycerides, and from these results, the low-density lipoproteins cholesterol level is calculated, and which is referred to as calculated low-density lipoprotein. Triglyceride levels are generally a reflection of glycemic control, meaning that when glucose levels are high, triglycerides will also be high. The high-density lipoprotein levels indicate severity of insulin resistance, and low high-density lipoprotein cholesterol is seen frequently in insulin-resistant individuals. In renal tests, an early indication of renal disease associated with diabetes is microscopic protein loss in the urine, measured by the amount of albumin, which is called microalbuminuria. Significant loss of albumin into the urine is associated with renal damage and the risk for development of end-stage renal disease. Some 2 other standard lab tests to assess renal function are blood urea nitrogen and creatinine. So that's BUN test and a creatinine test. Then the last one is C-reactive protein, which is made by the body during times of stress or infection. It's often elevated in those with diabetes and is associated with the inflammatory process of insulin resistance and cardiovascular disease risk. This can be elevated in those with inflammatory processes such as rheumatoid arthritis. So, primary prevention measures for optimal glucose regulation emphasize healthy lifestyle behaviors. The general measures include maintaining optimal body weight, regular physical activity, and eating a balanced diet. It's found that those with prediabetes could reduce the progression to type 2 by 58% through the combination of exercise for 30 minutes, 5 days a week, and a modest weight loss of 7% body weight. Also, metformin can also reduce progression to diabetes by 31% and is a recommended diabetes prevention strategies for those younger than age of 60 years with prediabetes. So, in maintaining optimal body weight, we have to remember that obesity is directly linked to insulin resistance and the development of diabetes. The increase in diabetes prevalence in recent years correlates directly with the increase in overweight and obesity and the decline in regular physical activity during the past 2 decades. For exercise dramatically improves insulin resistance and cellular metabolism by increasing the number of GLUC4 transporter molecules within muscle cells, thus facilitating glucose diffusion into the cell and lowering glucose levels. So in diet, primary prevention further includes avoiding excess calorie intake, sweet drinks, and striving for a healthy weight. We want to emphasize consuming a diet high in whole grains, fruits and vegetables that are deep orange in color, leafy green vegetables and legumes, along with low-fat milk and a variety of lean protein sources. So, secondary prevention refers to the early detection of disease through screening. Population-based screening recommendations vary across organizations, although blood glucose screening among adults with risk factors for diabetes and among all pregnant women after 24 weeks of gestation is widely recommended. There are no specific recommendations for population-based screening for hypoglycemia. Now, for individuals with diabetes, there are several regular screening measures for early detection of complications. It's recommended that HbA1c measurements are taken at least twice per year or every 3 months if not meeting glycemic targets. Also, annual renal function tests, annual dental, foot, and dilated eye examinations, and those with type 1 diabetes are at a higher risk for other autoimmune processes, and therefore thyroid function is monitored annually. So, management of conditions within the diabetes syndrome requires an interdisciplinary approach, with glycemic control as the goal to which all interventions are geared. Specific collaborative interventions include patient education for self-management, glucose monitoring, nutrition therapy, and pharmacological agents. So, some of the patient education you can do, you're wanting to aim at promoting self-care behaviors for those with diabetes. We can provide insight into management decisions, but the diabetic patient is involved in daily decision making for their disease management. Their self-care behaviors is a component of diabetes management and includes diet, exercise, weight control, loss, medication management, getting adequate rest, and maintaining awareness of complications. Also, in monitoring and managing their blood glucose, this involves regular monitoring of their blood glucose level and using this data to determine medication or dietary action to correct an imbalance. So we can also provide nutrition therapy because nutrition therapy is a cornerstone of diabetic management. Individualized dietary strategies should be developed in conjunction with the patient in accordance with his or her needs, readiness, and ability to alter their lifestyle. For patients with type 2 diabetes, education often includes strategies to facilitate weight loss. And most individuals with insulin resistance, reactive hypoglycemia, or type 2 diabetes tolerate a range of up to 50 to 60 grams of carbohydrates per meal very well, and especially if the meal is low in glycemic index. Nutrition education for those with type 1 diabetes is focused on knowledge of various nutrient components of each meal to optimize nutrition as related to insulin therapy. When we talk about pharmacological agents, we are emphasizing an individualized approach of medication therapy for those with diabetes, in which factors such as life expectancy, support system, comorbidities, patient engagement, and understanding of the disease process, risk for hypoglycemia, disease duration, and vascular complications are considered when creating a medication management plan. So we have some oral hypoglycemic agents, and these are used in the treatment of type 2 diabetes and help to manage glycemic control by reducing insulin resistance and enhancing insulin secretion. So we have insulin sensitizers, which is the first line oral agent for type 2 diabetes. Metformin is going to be one of the insulin sensitizers, as well as pioglitazone, and both metformin and pioglitazone will help correct the defect of insulin resistance seen in type 2 diabetes. Then we have insulin secretagogues, which is the sulfonylureas, and the shorter acting non-sulfonylureas, which enhance insulin secretion from the pancreas, but are effective only for those who have effective insulin secreting capacity in the pancreas. So the more you take these, they typically become increasingly less useful. Then we have incretin agents, and the incretin drugs reduce postprandial glucose levels, and they are weight neutral or facilitate weight loss. Then we have SGLT2 inhibitors, and these agents increase the amount of glucose excreted by the kidneys and are associated with some weight loss. They cause an osmotic diuresis and increase risk for dehydration and orthostatic hypotension. They can also get insulin. So patients who require insulin replacement need both basal and mealtime insulin. So basal is long-acting insulin, and then the mealtime would be short or fast-acting insulin, because we want to achieve euglycemia, which is normal blood sugar levels. Normal insulin secretion patterns consist of steady secretion of very small amounts of insulin throughout the day and night, with pulsations of insulin secretion at meal times. Insulin replacement therapy attempts to mimic this normal pattern by using basal and mealtime insulin, and the following types of insulin replacement therapy are used. So basal insulin therapy can be provided with either protamine hagedorn insulin, which is NPH insulin, glarine, or detamir insulin. Mealtime insulin therapy can be provided with regular insulin or rapid-acting analogs such as Lispro, Aspart, and glulisine insulin. And there are also mixed preparations. So mixed insulin preparations combine long-acting basal insulin with mealtime insulin. So some examples are 70-30 NPH and Lispro, 70-30 NPH in regular, and 75-25 NPH in Aspart. Glucose regulation affects and is affected by most, if not all, physiological processes. As the primary energy substrate, all life processes are dependent on normal glucose metabolism and regulation. In this figure, it shows some of the most important interrelated concepts. Hormonal regulation is shown as a close interrelated concept because of the significant influence that hormones have on the regulation of glucose. Proper nutrition and regular physical activity, so mobility, are needed for optimal regulation of glucose concentration and management of conditions in which regulatory mechanisms are impaired. Long-term consequences of hyperglycemia lead to micro and macrovascular changes, so perfusion, poor wound healing, which is tissue integrity, and impaired immune function, which is immunity, and reduced renal function, elimination, and changes in vision and peripheral sensation, sensory perception. The concepts family dynamics, adherence, and culture influence the behavioral changes needed for optimal health promotion or disease management. Family relationships can suffer when attempts to regulate the diet of one individual has an adverse impact on mealtime that affects other family members. This can result in mealtime-associated stress if optimal family dynamics are not present. Patient education is a cornerstone of treatment and has a tremendous impact on outcomes for those with impaired glucose regulation. Question number 1. What is the only hormone produced that lowers elevated blood glucose levels after carbohydrate intake? 1. Glycogen. 2. Insulin. 3. Epinephrine. And 4. Glucagon. The answer is number 2, insulin. Insulin is the only hormone produced that lowers elevated blood glucose levels after carbohydrate intake. Question number 2. How do infection and other high-stress conditions affect the need for insulin? 1. Increase the need for insulin. 2. Decrease the need for insulin. 3. Have no effect on insulin needs. 4. It is not known if infection and stress change insulin needs. It's going to be number 1. Glucose regulation is impaired with altered hormonal states. Increased need for insulin is found with infection and other high-stress conditions such as traumatic injury, cancer, and surgery. Question number 3. An A1C measurement can better diagnose impaired glucose tolerance and diabetes as related to elevated postprandial blood glucose levels. What level is indicative of diabetes? 1. Less than 5%. 2. Less than 6%. 3. Greater than 6.5%. 4. Greater than 1%. The answer is going to be number 3. An A1C reading of greater than or equal to 6.5 is indicative of diabetes. So, diabetes mellitus is a metabolic disorder of the pancreas, which affects the carbohydrate, fat, and protein metabolism. It's believed that diabetes in adults is a consequence of metabolic syndrome. So this includes obesity, especially in the abdominal area, high blood pressure, elevated triglycerides, low density lipoproteins, blood glucose levels, and a low high density lipoprotein level. When we're talking about diabetes, there's no age group that is exempt from being diagnosed with diabetes. There's about 29.1 million Americans in the U.S. with diabetes, and there's about maybe 8.1 million that are yet undiagnosed. The highest incidence in those with diabetes mellitus are people over 65 years of age, especially in Native Americans, Alaskan Natives, and non-Hispanic African Americans. So at present, diabetes is actually the 7th leading cause of death in the U.S. And because of the chronic nature of diabetes, the ones that are diagnosed have many debilitating and life-threatening complications before death. So they experience higher mortality, reduced functional status, and an increased risk for institutionalization. Now, when we're talking about diabetes, we have to know that there's 2 different types. There is type 1, which is formerly called insulin-dependent diabetes mellitus, and this is characterized by an absence of insulin production by the beta cells in the islets of Langerhans in the pancreas. The onset of type 1 diabetes is more likely in people younger than 20 years of age, and it accounts for approximately 1.25 million of all diagnosed cases of diabetes. Now, when we talk about type 2, this is formerly known as non-insulin dependent diabetes. And this is characterized by insulin resistance or insufficient insulin production that may or may not result in the eventual need for insulin therapy. And type 2 diabetes is more common in aging adults. So in roughly around 2013, adults aged 45 to 64 years were the highest among newly diagnosed age groups for type 2 diabetes. We also found that type 2 diabetes is being detected in obese children. Question number 1. Is the following statement true or false? Diabetes mellitus is a disorder of the pancreas affecting sugar metabolism. False. Diabetes mellitus is a disorder of the pancreas affecting carbohydrate, protein, and fat metabolism. So there's something called prediabetes, and this is something that the American Diabetes Association came up with because there's criteria where we can identify people with what we call prediabetes. And what prediabetes is it's a list of criteria that the person can have that can lead to type 2 diabetes, heart disease, and stroke. So people with prediabetes are generally overweight or obese. They have risk factors for diabetes and may have one or more abnormal blood glucose levels, such as their hemoglobin A1C, fasting blood glucose, or oral glucose tolerance, or all three. A person with a hemoglobin A1C of 5.7 to 6.4%, a fasting glucose level of 100 to 125 after an overnight fast, or an oral glucose tolerance test of 140 to 199 after a glucose tolerance test lasting 2 hours is considered pre-diabetic. So again, somebody with an HbA1c of 5.7 to 6.4, a fasting blood glucose of 100 to 125, or a oral glucose tolerance test of 140 to 199. If you have any of these, you are considered to be pre-diabetic. Now, just because somebody has pre-diabetes, though, doesn't mean that they are guaranteed to get type 2 diabetes. You can actually delay or maybe avoid type 2 diabetes with weight loss and increased physical activity. But in saying so, there are a significant number of people that have prediabetes that will eventually develop type 2 diabetes. And that's because, habits are kind of hard to kick. So hyperglycemia is an elevated blood glucose level, which is associated with other disorders or their management. So, for example, pancreatitis causes both exocrine and endocrine disturbances, right? When there's a production of adrenocortical hormones and it's excessive, like you would see in Cushing syndrome, or with the administration of glucocorticoid drugs for immunosuppressive purposes, we get secondary diabetes. And impaired glucose metabolism and hyperglycemia also are associated with drugs such as loop and thiazide diuretics, antipsychotics, levodopa, and oral contraceptives, and with the administration of total parenteral nutrition. Insulin can be used in management of these disorders, but it doesn't indicate that the client has diabetes. So you can have hyperglycemia without actually having diabetes. We can put in, regimens and medications that'll bring it back to normal, and their normal blood glucose level can be restored. Okay, so let's talk about type 1 diabetes. So insulin has three functions, okay? It carries glucose into body cells as their preferred source of energy. It will promote the liver storage of glucose as glycogen, and it will inhibit the breakdown of glycogen back into glucose. So in type 1 diabetes, the islet cells or endocrine portion of the pancreas ceases to produce insulin. And without the insulin, the blood glucose level rises beyond its normal range. Sometimes it can go from anywhere from 300 to 1,000. And when that happens, the body breaks down fat and protein as alternative sources of cellular energy. Essentially, we need energy to survive, right? And if it can't use the insulin, it's going to go to other places. So the breakdown of fat is known as lipolysis, and this results in the accumulation of fatty acids and ketones, metabolic byproducts of fat metabolism. And when ketones accumulate in the blood, clients with diabetes are prone to developing a form of metabolic acidosis known as ketoacidosis. And in type 1 diabetes, ketoacidosis develops quite suddenly because of the total cessation of insulin production. So your body's not producing any insulin. So essentially, our body will try to compensate, and that's when it will go into ketoacidosis. So type 1 diabetes is considered to be an autoimmune disorders. We have found that with research, killer CD8 T cell lymphocytes will attack and destroy the insulin-producing islet cells. And so the theory is that people with type 1 diabetes lack a protein marker known as major histocompatibility complex, or MHC, that helps the T cells identify natural cells as themselves. So because these T cells misidentified their islet cells as a natural, they destroy them. So in the same research, they have now found a way to destroy the islet attacking T cells using tumor necrosis factor. And so again, this is kind of like a ongoing insulin curing type of thing that's being researched at Massachusetts General Hospital at the time. Anyways, so there is good news of a possible cure for a type 1 and those with type 2 diabetes who might eventually require insulin. Okay, so let's talk about type 2 diabetes. So diabetes mellitus, especially type 2, it will run in families, although we haven't really found a specific gene for diabetes. The consensus is that type 2 diabetes is an inherited disease, and that obesity, especially intra-abdominal obesity, is likely a cofactor that triggers its onset. Scientists possibly have found the link between obesity and type 2 diabetes, and their findings show that chronic low-grade inflammation results in insulin resistance. And a decreased sensitivity to insulin at the tissue level, as well as type 2 diabetes. So their belief is that anti-inflammatory therapies could play a really big role in the prevention and treatment of type 2 diabetes that then causes changes in liver function accompanied by hyperglycemia and insulin resistance. Question number 2. Is the following statement true or false? Type 2 diabetes mellitus occurs as a result of lack of insulin production. False. Type 2 diabetes mellitus occurs as a result of insulin resistance or insufficient insulin production. Type 1 diabetes mellitus is caused by no insulin production. So let's go back to type 2 diabetes. Now, when type 2 diabetes is manifested, the beta cells of the islets of Langerhans secrete increased levels of insulin into the bloodstream to offset the hyperglycemia. But the blood glucose level remains higher than normal because there's a deficiency of transmembrane glucose transporters on the surface of the cells. Now, these transporters form channels that facilitate diffusion of glucose into the cells, and they might only function at 20% in efficiency in people with type 2 diabetes. Now, this contributes to hyperglycemia. Exercise can increase transmembrane glucose transporter levels in skeletal muscles, which explains why exercise will help reduce blood sugar. Eventually, when we overstimulate the beta cells, they become exhausted, and this results in a decline in insulin production, and those with type 2 diabetes may become insulin deficient, like those with type 1 diabetes. So the correlation of obesity, sedentary lifestyle, and insulin resistance helps explain how dieting, exercise, and weight loss control type 2 diabetes, and delays, reduces, or eliminates the need for medications to treat the disease. Now, when we have an excess level of glucose in the blood, this leads to glycosuria, which is glucose in the urine. and urinary excretion. And glycosuria appears when the blood glucose level rises above 180. So at this level, the kidney's renal threshold, and what renal threshold means is the ability to reabsorb glucose and return it to the bloodstream. So when their blood glucose is at 180, the kidney's renal threshold is impaired. So they can't reabsorb glucose and return it to the bloodstream like they usually do. So the hypertonicity from concentrated amounts of glucose in the blood, it pulls fluid into the vascular system, which will result in polyuria, which is excessive urine production. So it pulls glucose into the urine, and you're automatically also urinating excessively. So the client usually experiences urinary frequency accompanied by increased excreted urine. Because so much water is lost, they might get polydipsia, which is excessive thirst. Let's see. And then while the needed glucose is being wasted, the body's requirement for fuel continues. So we still need energy, but our body is wasting the glucose. So the person with diabetes will now feel hungry and eat more, which is called polyphagia. Now, despite eating more, he or she loses weight as the body uses fat and protein to substitute for glucose, because again, the body won't use the glucose, right? So it'll use our fat and protein. Now, ketones, a chemical intermediate product in fat metabolism, will cause ketoacidosis when they accumulate. Now, our body will try to adapt, and we have a bicarbonate buffer system that will try to neutralize the ketones, but in doing that, we get ketonemia, which is increased ketones in the blood, causing a decreased alkali base reserve, which leads to acidosis. A lot of the times when we see somebody with ketoacidosis, we also see Kussmaul's respirations. And if you guys remember, that's a really fast, deep, labored breathing. And we can actually smell acetone, which is volatile, by the way. We can smell acetone on their breath, and because it has this very characteristic fruity odor. So if we don't do treatment, the outcome of ketoacidosis is circulatory collapse, renal shutdown, and death. So ketoacidosis is more common in people with diabetes who no longer produce insulin, such as those with type 1 diabetes. But in saying that, people with type 2 diabetes are more likely to develop hyperosmolar, hyperglycemic, non-ketotic syndrome because with limited insulin, they can use enough glucose to prevent ketosis, but not enough to maintain a normal blood glucose level. We also have to remember that infection and stress invites ketosis because they increase the demand for insulin, which the pancreas cannot accommodate in those with diabetes. So in addition, people with diabetes mellitus are at an increased risk for vascular disorders such as atherosclerosis, cerebrovascular accidents, myocardial infarction, peripheral vascular disease with the decreased ability to heal, renal failure, blindness, and neuropathy. So as we talked about type 2 diabetes and why we get polyuria, polydipsia, and polyphagia, these are the three classic symptoms that we need to be watching out for in diabetes mellitus. So polyuria, excessive urination; polydipsia, excessive thirst; polyphagia, excessive hunger. Some other symptoms that we can look out for are weight loss, weakness, thirst, fatigue, and dehydration. They generally have an abrupt onset in clients with type 1 diabetes, whereas those with type 2 diabetes, it's a lot more gradual. We can also watch out for skin, urinary tract, and vaginal infections, possibly because the elevated level of blood glucose supports bacterial growth. We can also watch out for any changes in visual acuity, which can be manifested by blurred vision, and things like that. Some diagnostic things we can do. We can screen for detection in blood and urine. Normally, urine won't have any detectable glucose or ketones in diabetes. But because the body fails to use glucose adequately, it will excrete glucose in the urine. So again, normally we won't have glucose or ketones in our urine, but in diabetes we might. If the body metabolizes fats faster than it used to in ketones, ketones can also appear in the urine. We can also do blood sugar testing, such as a random blood sugar, fasting blood glucose, oral glucose tolerance test. One of the quick and the most common methods that most of us are going to use in the field is a blood sugar testing using a glucometer. So a glucometer measures capillary blood glucose from blood sampled from a finger stick. Now, this is the doctor's recommended self-monitoring of blood glucose levels that most will do at home while taking insulin, especially clients with unstable diabetes or frequent hypoglycemic episodes. Ideally, we'd like their blood sugar to range from 90 to 130 before meals and less than 180 1 to 2 after meals, 1 to 2 hours after meals. A glucometer can be used to obtain blood sugar levels from alternative sites such as the upper arm, forearm, thigh, or calf. And they're generally less painful or even painless because the fingertips have a higher number of nerve endings on them. We can also do a glycosylated hemoglobin or hemoglobin A1C, and this just tests to see the amount of glucose stored by hemoglobin is elevated above 7%. So this shows us a more long-term versus a finger stick is a little bit more short-term. So in managing diabetes, the treatment depends on a lot of different factors, such as the type of diabetes you might have and the ability of the pancreas to manufacture insulin. And it involves the combination of the following. So medical management depends on your diet and weight loss, exercise, insulin, oral anti-diabetic agents, pancreas transplantation, and islet cell transplantation. So diet is a major component of treatment for every person with diabetes. A formulation of a diabetic diet depends on the client's sex, age, height and weight, activity level, occupation, state of health, former dietary habits, and cultural background. So sometimes the dietitian, the nutritionist, or your doctor will give you certain dietary allowances. So calories, percentages of carbohydrates, fats, and proteins that are prescribed that you have to stay within. And the patient is given a diet prescription and a list of substitutions and choices to vary the diet. So, for example, the doctor will determine whether or not the client with diabetes may have 1,500 calories a day. The calories are then distributed according to the percentage of carbs, fats, and proteins that equal the total prescribed caloric amount. So a dietitian provides the client with a list of foods in 6 different categories, such as starch, bread, protein, which can be animal or plant-based, vegetable, fruit, milk, and fat, and indicates how many items they can have from each category. They will then give a client a list of foods in each category and their equivalent amounts, and the person might be able to substitute one food in the list for another in the specified amount for a variety. For exercise, exercise can help metabolize carbohydrates and control blood glucose levels because glucose transporting receptors are within the skeletal muscles and allow the muscles to take in glucose from the blood independent of insulin. Now, this provides energy during exercise and lowers the blood sugar. And so exercise will then reduce the need for insulin because blood sugar can be lowered without it, which is an advantage for those with diabetes. It also explains why hypoglycemia can also accompany exercise. Now, we need to remember that exercise also improves the circulation of blood, which is then compromised in the client with diabetes. So, exercise also lowers cholesterol and triglyceride levels and improves muscle tone. So, an exercise program for the client with diabetes specifies the type of exercise and length of time to perform it. Generally, it's recommended that adults with diabetes perform at least 150 minutes of a week of moderate intensity aerobic physical exercise that spreads over at least 3 days a week with no more than 2 consecutive days without exercise. So when we're talking about insulin, for those with type 1 diabetes, they must rely on insulin therapy. The goal of the pancreas and islet cell transplantation, which is performed only for clients with type 1, is that the client will acquire insulin dependence. And that is that the client's own naturally produced insulin will regulate blood glucose levels within consistently normal ranges. The use of techniques to reverse the autoimmunity or to stimulate islet cell regeneration with gene therapy may eventually cure clients with type 1 diabetes. Until then, those with type 1 diabetes will need to continue to require daily, multiple, or continuous injections of insulin. Those with type 2 diabetes might become dependent on insulin therapy when their beta cells cease to function and anti-diabetic agents are no longer effective. So, when we're talking about insulin and we're talking about preparing insulin, they're divided into 4 categories, which is rapid acting, short acting, intermediate acting, and long acting. Some patients with type 2 diabetes will maintain their glycemic control with a once daily injection of an intermediate acting insulin with a combination of intermediate acting and short acting. So it might be like a 70-30 proportion or a 50-50 proportion, or just use a long-acting insulin. Those with type 1 diabetes will self-administer 3 to 4 injections or more throughout the day unless they're using an insulin pump. So when we're talking about the administration of insulin, insulin is described in units. So U100 means that 1 ml contains 100 units of insulin. Inhaled insulin is supplied in 4-, 8-, and 12-unit single-use cartridges. The physician will then specify both the dosage and the type of insulin to be used. When combining 2 types of injectable insulin in the same syringe, the short-acting insulin is withdrawn into the syringe first, and the intermediate-acting insulin is added next. We call this, quote unquote, clear to cloudy because short-acting insulin is clear and the intermediate-acting insulin contains an additive that makes it cloudy. The mixture is then administered within 15 minutes to ensure that the onset, peak, and duration of each separate insulin remain intact. Lantus and Levemir, which are long-acting insulins, absolutely can be not mixed with any other type of insulin in the same syringe. There are common mixtures of insulin such as Humulin 730, 70-30, Novolin 70-30, and Humulin 50-50, which eliminates the need for mixing insulin from 2 separate vials. We can also administer insulin intravenously and subcutaneously. The IV route is to treat severe hyperglycemia or prevent or control elevated blood sugar by adding it to a total parenteral nutrition solution that contains a high concentration of glucose. The one that we're going to do the most is the subcutaneous route. And this is most commonly used for administering insulin because it's absorbed more rapidly when injected in the abdomen than in the arms or the thighs. Clients with diabetes are taught to use the abdomen for self-administration of insulin, and Subcutaneous injections require rotation to avoid lipotrophy, which is the breakdown of subcutaneous fat at the site of repeated injections, and lipohypertrophy, which is the buildup of subcutaneous fat at the site of repeated injections, either of which will eventually interfere with insulin absorption in the tissue. Some other techniques for injecting insulin can be an insulin pen, a jet injector, or an insulin pump. An insulin pen is a device where there's a cartridge and it contains about 150 to about 300 units of insulin, and it's loaded into this injecting pen and with a disposable needle. And so each time the insulin is injected, a new needle is attached. And you use this dial to determine like how many units you need, and you just press it against their skin, and it's relatively easy, and most of the time it's painless. There's also something called a jet injector, and the jet injector uses high pressure and rapid speed rather than a needle to instill insulin through the skin. And the pressure transforms the liquid into a fine mist that is then distributed over a wide area of tissue, resulting in faster absorption. Although there are some advantages to this, such as reducing pain at the site and eliminating the use of needles, the cost tends to make this a little less practical. There's also an insulin pump, and this is a means for delivering insulin by continuous infusion. So the device has three components, which is pump, tubing, and a needle. And the pump itself contains a reservoir for rapid-acting or short-acting insulin, a battery-operated infuser, a computer chip that enables a person to regulate continuous bolus doses, and the pump, which is worn in a pouch or a belt holder and attached to tubing with a needle. The needle is then inserted into the subcutaneous tissue in the abdomen and can remain in the same site for up to 3 days. Clients who are interested in controlling their diabetes with an insulin pump need to consider both its advantages and disadvantages. So with an insulin pump, some of the advantages are it resembles the normal pancreatic release of insulin. It decreases the necessity for multiple injections. It helps maintain consistent blood sugar levels, provides more flexibility for eating food, and facilitates the installation of smaller doses. But some of the disadvantages is that it requires high motivation to control diabetes by frequently checking blood glucose levels and adjusting the infusion. It can create a potential for hyperglycemia if it fails or the tubing becomes kinked or obstructed. It can also interfere or create a nuisance factor when participating in active sports, sexual intercourse, or bathing, because although the pump can be temporarily disconnected without removing the needle, but doing so stops the delivery of insulin, and it has to be disconnected, or it has to be reconnected, sorry. So let's talk about oral anti-diabetic agents. So sulfonylureas such as glyburide and glipizide, they're modified from sulfa-containing antibiotics when it was found that they reduce the blood glucose level. So these sulfonylureas have evolved through several generations, and the meglinotides and non-sulfonylureas such as repaglinidide are often described as being insulin releasers because they stimulate the pancreas to secrete more insulin. But although they are effective drugs, they generally tend to cause weight gain, hypoglycemic reactions, secondary failure, and a phenomenon in which the pancreas can't continue making sufficient insulin, perhaps as a result of the gland's overstimulation. Then we have biguanides and TZDs. And metformin is the only biguanide approved for use together with the thiazolidiniodones, which include rosiglitazone, and pioglitazone, and are categorized as insulin sensitizers. Insulin sensitizers, so the biguanides and TZDs help tissues use available insulin more efficiently. Now, metformin doesn't promote weight gain like the sulfonylureas, but it does not trigger low blood glucose levels. But however, it can cause an upset stomach, flatulence, diarrhea, and is associated with a small risk of lactic acidosis. TZDs, on the other hand, are known to cause weight gain, edema, liver damage, heart failure, heart attacks, and bladder cancer. So anyone taking a TZD should have liver function tests performed every 2 months during the first year of treatment. Cardiac complications associated with the use of rosiglitazone led to a proposal that this drug must be withdrawn, but it continues to be available from certified mail or order pharmacies. We also have alpha glucose glucodase inhibitors, and these are drugs such as miglitol and acarbose. They are an intestinal enzyme that breaks down complex carbohydrates into glucose, a simple sugar. And when this enzyme is inhibited, the process of forming glucose is slowed, and glucose is absorbed more slowly than from the small intestine. And consequently, the blood glucose is balanced with the body's available insulin. Now, drug is in so the alpha glucosidase inhibitors must be taken 15 minutes before each meal. They are most effective in reducing postprandial hyperglycemia. Occasionally, those with type 1 diabetes take both insulin and alpha glucosidase inhibitors because this category of drug tends to equalize blood glucose levels and prevent swings between hyperglycemia and hypoglycemia. So let's talk about pancreas transplantation. So replacing the pancreas involves a whole or partial organ transplant, and the usual candidate for for pancreas transplantation is somebody with type 1 diabetes who has renal failure and will benefit from a combined kidney and pancreas transplant. Those with type 2 are usually not offered this option because their problem is insulin resistance, which won't improve with a transplant. Because pancreas is both an exocrine and endocrine gland, transplanting it requires a mean for exocrine enzymatic drainage and venous absorption of insulin. The exocrine drainage is accomplished by establishing a duodenal or urinary bladder connection with the transplanted pancreas. And then the insulin is then released into the portal vein, which carries blood to the liver. Although bladder connections have a lower incidence of organ rejection, they tend to cause urologic complications and are used less often than originally. So again, in any kind of transplant, they have to be on lifelong immunosuppressive drug therapy because without it, the organ will be destroyed. And because type 1 diabetes can be managed with insulin, many experts believe that the risk involved with immunosuppression outweigh the benefit that can be achieved with a pancreas transplant, unless a kidney transplant is also necessary. Now we go into islet cell transplantation. So some people with type 1 diabetes are recipients of islet cell transplants, which is the insulin producing components of the pancreas, rather than a transplant of the entire organ or part of the organ. One human organ donor pancreas, but more often two or a portion of the pancreas from a living donor is necessary to obtain sufficient numbers of islet cells for a transplantation. So it's not just coming from one person, it's coming from two or more. The fragile islet cells must be transplanted soon after removal. And after the pancreas is harvested, the islet cells are separated from the tissue and injected through the abdominal wall into the client's portal vein, where they migrate to the liver and begin to release insulin. The bone marrow also is being used as an alternate transplant site. So islet cell transplantation surgeons use a combination of tacrolimus, sirolimus, and daclizumab to prevent rejection, and the current practice to avoid using a steroid with other immunosuppressive drugs because steroids will raise the blood glucose levels. and the new islet cells will have difficulty overcoming that. However, progress is being made to prevent rejection and avoid lifelong immunosuppression by encapsulating the islet cells in a subcutaneous implanted chamber that acts as an immuno barrier. Those that get the transplanted islet cells tend to lose their ability to function over time, and approximately 70% of recipients will resume insulin administration within 2 years. However, the amount of insulin and the frequency at which they used to take it before are reduced because they have a little bit more control of blood glucose levels. So diabetic ketoacidosis, or I'm going to call it DKA, is a potentially life-threatening metabolic acidosis. And this occurs when there is an accumulation of ketones. And ketones comes from fat metabolism when the cells can't use glucose for energy. So because they can't use glucose, they will use your fat or your proteins, and that's when you get ketones. This occurs as a consequence of an acute insulin deficiency or an inability to use whatever insulin the pancreas secretes. Now, DKA is sometimes the event that will actually lead to an initial diagnosis of diabetes. So, DKA can develop despite the patient's adherence to their prescribed treatment program. Those that develop DKA often have a severe, very hard to control form of diabetes, and they usually have brittle or unstable diabetes. Every so once in a while, we will get a patient in the hospital in DKA that has undiagnosed diabetes. Some of the other causes of DKA are infection and non-adherence to their treatment. When the amount of glucose that's transported across cell membrane decreases, the liver will actually increase its production of glucose. Now, in that case, because it's doing that, the blood glucose level becomes extremely elevated, and the kidneys will attempt to excrete the glucose, which is beyond what they can handle, and in the process, excessive amounts of water, sodium, and potassium will also be excreted as well. At this point, the patient will become dehydrated, their skin is warm and dry and flushed, and their stored fat will be broken down, which causes their ketones to accumulate in the blood and the urine. Now, as the ketones accumulate, the pH of the blood becomes acidic. And you'll find that they'll start breathing rapidly and deeply, so like a Kussmaul respiration, and to eliminate their carbon dioxide and prevent it from forming carbonic acid. If they stay in this condition for too long and it's too severe, they will eventually become comatose. If we do not treat DKA quickly enough, it can result in death. Now, when we are assessing somebody with DKA, the early symptoms tend to be a little bit vague, and as time goes on, the symptoms become a little bit more definite and serious because the ketones are accumulating in their bloodstream. What we'll see is weakness, thirst, anorexia, vomiting, drowsiness, and abdominal pain. We'll find that their cheeks are flushed and the skin and the mouth are dry. Their breath will kind of have like a very fruity, odor because it's the odor of acetone. You'll find that they'll have Kussmaul's respirations. Their pulse is going to be rapid and weak. Their blood pressure low. They might be unresponsive but restless. And you'll find that their blood glucose levels are elevated from 300 to 1,000, anywhere in between that. Their urine's going to contain glucose and ketones, and their blood pH will range from 6.8 to 7.3, and their serum bicarbonate level might be decreased to levels from 0 to 15. And then you can find that their partial pressure of carbon dioxide, it might decrease to 10 to 30, and we have to check their serum sodium and potassium levels because we have to see out to what degree they are dehydrated. Question number 3. Is the following statement true or false? Diabetic ketoacidosis results from a client being a brittle diabetic or non-compliance with diabetes mellitus treatment. True. Diabetic ketoacidosis results from a client being a brittle diabetic or non-compliant with diabetes mellitus treatment. It typically occurs in type 1 diabetes mellitus. So, treatment for DKA depends on the severity of DKA. The main goals of treatment are to reduce the elevated blood glucose, correct fluid and electrolyte imbalances, and clear the urine and blood of ketones. So, in order to accomplish these, insulin is given intravenously. Insulin reduces the production of ketones by making glucose available for oxidation by the tissues and by restoring the liver's supply of glycogen. Regular insulin is added to an IV solution and infused continuously. The amount of insulin and the rate of infusion depend on the blood glucose levels, but the rate may be in the range of 5 units an hour. Isotonic fluid is instilled at a higher volume, for example, like 250 to 500 ml an hour for several hours, and will then become adjusted once the client becomes rehydrated and their diuresis is like less acute. As insulin begins to lower the blood glucose level, the IV solution is then changed to include one with glucose. And this helps to kind of avoid the potential for hypoglycemia. And we can do potassium replacement for elevated serum levels to raise intracellular stores. And we want to monitor their serum electrolytes and blood glucose levels if necessary. We also want to monitor their IV fusions closely, take their vital signs frequently. When older adults with diabetic ketoacidosis, when they go into DKA, they're generally prone to fluid overload if they have cardiopulmonary or renal disorders. So we definitely need to watch out for that. We can also maybe insert an indwelling catheter and monitor urine output for those to make sure that their replaced potassium has a means for excretion, check on their serum electrolytes, maybe do some cardiac monitoring with cardiac leads, monitor their blood glucose levels frequently, and monitor their urine for the presence of ketones. So, hyperosmolar hyperglycemic non-ketoic syndrome is an acute complication of diabetes. It's also called HHNKS. This is characterized by hyperglycemia without ketosis, and it's not unusual to find the blood glucose level well over 500. But the pH of the blood remains within the normal range of 7.35 to 7.45. But we do get fluid and electrolyte imbalances that accompanies HHNKS. Now, HHNKS often will result from a serious illness during which the metabolic needs exceed the limits of available insulin. So essentially, because of this persistent hyperglycemia, the fluid will move from the intracellular compartment to the extracellular compartment. And diuresis will occur with a subsequent loss of sodium and potassium. Now, because they're still secreting some insulin and can transport glucose in the cells, fat metabolism is minimal or unaffected. So basically, ketosis doesn't develop. Now, HHNKS is more common in undiagnosed or older clients with type 2 diabetes, and it occurs among clients who do not have diabetes who receive drugs that elevate the blood glucose or require kidney dialysis or total parenteral nutrition. Now, when we assess somebody with HHNKS, we are looking for hypotension, mental changes, extreme thirst, dehydration, tachycardia, and fever. Some neurological signs that we need to watch out for as well are paralysis, lethargy, coma, seizures. And we need to watch out for symptoms of hypokalemia and hyponatremia. When you do the physical examination, you'll find that somebody that has HHNKS has really dry mucous membranes and really poor skin turgor. Their blood glucose levels are usually exceedingly high, and their serum potassium and sodium levels generally tend to stay low. So in order to take care of this, treatment will include the administration of insulin and correction of fluid and electrolyte imbalances. We might also put in a central catheter to monitor the client's hemodynamic response to fluid replacement. We want to monitor the blood glucose level, assess for electrolyte imbalances, dehydration, implement any medical orders for insulin, fluids, electrolyte replacement, and monitor whether or not the patient is responding well to treatment. Our priority areas on what we need to assess for is hydration status, intake and output, skin turgor, vital signs, electrolyte studies. We want to make sure that we're keeping an eye on their neurologic and cognitive symptoms because their cognition might be significantly impaired in the early stages of care. So hypoglycemia is a low blood glucose level, and it's a potential adverse reaction when administering medications for diabetes. Now, when there's too much insulin in the bloodstream, when in comparison to the amount of available glucose, that's when hypoglycemia happens. The blood glucose will generally fall below 70. And because glucose is the primary source of energy, especially for the brain, hypoglycemia tends to manifest in neurologic changes such as confusion, difficulty processing information, anxious feelings, emotional irritability, and headache. Sometimes the patient will feel hungry, which is a mechanism to stimulate eating, to try and accommodate, to make sure that they're trying to adapt. If this condition isn't treated, seizures, permanent brain damage, and death can rapidly occur. Now, hypoglycemia occurs when a patient with diabetes is not eating at all and continues to take insulin or oral anti-diabetic medications, or isn't eating enough calories to compensate for glucose-lowering medications. They might be exercising more than usual, which again will lower their available blood glucose. Also, alcohol consumption can interfere with the liver's ability to synthesize glucose from non-carbohydrates, which will place those patients with diabetes who drink at a higher risk for hypoglycemia because the effect may persist for up to 24 hours. So the pattern of symptoms that kind of happen with hypoglycemia, it's individual. They kind of vary, but the initial symptoms include tachycardia, weakness, headache, nausea, drowsiness, nervousness, hunger, tremors, malaise, and excessive perspiration. Some of the patients that have hypoglycemia have characteristic personality or behavioral changes. Some describe confusion and dizziness. Again, if the hypoglycemia isn't corrected, the symptoms can progress to difficulty with coordination. They might complain of double vision, unconsciousness, and seizures can develop. And again, so symptoms are going to vary with each person that has hypoglycemia. They have a very unique repetitious pattern that's individual to them. But the manifestation of hypoglycemia symptoms is usually pretty quick. It's pretty rapid, with unconsciousness or seizures occurring shortly after their onset. Now, when you find a patient with diabetes unconscious, you need to find out whether or not it's DKA or hypoglycemia, which are two very opposite things. They're very direct opposites. In ketoacidosis, the blood glucose level is really, really high, right? In DKA, it's high. In hypoglycemia, it's incredibly low. So you need to be able to be familiar with the symptoms of hypoglycemia and hyperglycemia and be able to differentiate the two. So if you look on page 943 of your book, on table 51-4, it will very distinctly tell you the different symptoms of hyperglycemia and then hypoglycemia. So in diagnosing hypoglycemia, diagnosis is all going to be based on your symptoms. We're going to check their history, their blood glucose levels. We need to differentiate between DKA and hypoglycemia. We need to determine whether or not they had insulin or any anti-diabetic drugs, if they've eaten, or, if they've had or received insulin very recently. The number one thing we're going to need to do is have a bedside glucometer test and continuously check on their blood sugar after administering medications. So the medical treatment for a hypoglycemic reaction is the administration of about 15 grams of simple carbs as soon as possible. So we have to determine whether or not the patient is conscious, though. So you do not want to feed somebody that is unconscious, correct? Because that's a swallowing risk. So if the patient is unconscious, glucose gel can actually be applied in the buccal cavity of the mouth. So the cheek area, you can apply the glucose gel because it will absorb into their cheek. If the patient does not respond after 2 administrations of rapidly absorbed carbohydrate, the doctor may order glucagon, which is a hormone that stimulates the liver to release glycogen, or 20 to 50 mLs of 50% glucose via IV. Once the hypoglycemic symptoms are relieved, the client with diabetes is then given complex carbohydrates such as graham crackers, milk, and to sustain and prolong an adequate level of blood glucose. Now, if the client is conscious and can swallow, you can give them an oral form of rapidly absorbed carbohydrates. So a lot of the time we'll give them glucose tablets or any kind of quick acting carbohydrates that are available. But in a more severe reaction, the nurse is going to want to provide more than, a offering of carbohydrates. If the symptoms do not, if they don't change and the blood glucose level remains low, we're going to coordinate with the doctor and see what else we can do to raise their blood sugar. And this might be IV glucose or parenteral glucagon. Now, above all, the nurse stays with the hypoglycemic patient until the pronounced symptoms are corrected. When hypoglycemia occurs, the regulation of glucose metabolism may be tenuous for about 24 hours. So it's kind of touch and go. And we have to make sure that they don't have further episodes of hypoglycemia. So as a nurse for somebody that's going through hypoglycemia, we want to ensure that the meal is served within 15 minutes of administering rapid acting insulin and within 30 minutes of giving short acting insulin. We want to ensure that the client eats the prescribed diet and between meal snacks. We want to inform the physician immediately if nausea, vomiting, or diarrhea occurs, or even if the patient refuses to eat. Always administer the correct type and dose of insulin at the prescribed times, and ask a colleague to check the label on the insulin vial and the number of units to double check to make sure you're not making a medication error. So one of the common complications with diabetes mellitus is peripheral neuropathy. Now, neuropathy is a general term that refers to pathological changes in nerves. And neuropathies in clients with diabetes can affect motor, sensory, and autonomic nerves. And neuropathies develop about 10 or more years after the onset of diabetes, but the incidence it increases with the duration. Now, because it's so gradual, they are usually pretty oblivious to the development in early stages. So neuropathy results from poor blood glucose control, and decreased blood circulation to nerve tissues. Now, what we'll see is that those with peripheral neuropathies are generally more common in patients with diabetes who smoke and their blood glucose level is really poorly controlled. Because nitric acid dilates blood vessels, some believe that consistently elevated blood glucose levels lower nitric acid levels and paracirculation and will then damage peripheral nerves. This may explain the development of erectile dysfunction in men with diabetes. Now, when motor nerves are affected, the muscle will weaken and then they'll atrophy, and that means that joint support is diminished. So then their feet will actually widen, and eventually their bone structure will actually be affected, resulting in skeletal deformities, usually in the feet and ankles, and that'll actually change the way that they walk. Areas of the skin and soft tissue that are subjected to friction and pressure are the most prone to ulcerate. So if there is an infection or impaired healing, portions of the affected extremity may require amputation. Now, there's sensory neuropathy and autonomic neuropathy. So in sensory neuropathy, this involves sensory nerves, which leads to paresthesias, which is abnormal sensations such as prickling, tingling, burning, or needle-like pain in the feet, legs, and sometimes hands. In more severe cases, feeling is totally lost, and this lack of sensitivity increases the potential for soft tissue injury without the patient even knowing. Now, in autonomic neuropathy, this affects organ functioning and has a few consequences. So, gastroparesis, which is atony of the stomach, basically slows the movement of food from the stomach. And if nerves that will innervate the bladder are affected, the client doesn't even have the sense to void, and the retained urine supports bacterial growth, causing frequent UTIs. They can also have incontinence that occurs when the bladder is overfilled. As many as 50% of men with diabetes develop erectile dysfunction because the nerves that promote erection will then become impaired. Autonomic nerves also affect cardiovascular function, and they usually will have episodes of orthostatic hypotension. So when we assess, one of the things that we need to assess for in peripheral neuropathy is pain. Pain is one of the leading symptoms that accompany motor and sensory nerve changes. The skeletal muscles in the extremities become smaller. Their feet will become swollen and insensitive to temperature or other tactile stimuli. Disturbing sensations will usually develop and intensify by maintaining a position for an extended period of time. So maybe standing in place, holding the steering wheel while driving, performing a repetitive motion such as knitting. They also complain of digestive, urinary, and sexual dysfunction and dizziness when rising. So let's talk about diagnostics. So a neurologic examination will validate that when a tuning fork is in contact with the skin of the extremities, the client will actually have a diminished vibratory sense. Some loss of protective sensation, the ability to sense and differentiate hot and cold, sharp and dull, soft and rough stimuli will occur. This is demonstrated when we are screening areas of their feet with a nylon monofilament that will deliver 10 grams of force without the client's perception. So it almost looks like a needle on a piece of plastic, and we go over the foot and they can't feel it. We can also do electromyography, which demonstrates a slowed conduction of electrical stimulation among the nerves. For medical management, we are going to try and control their blood glucose levels with diet, exercise, and medication. There's some medications that can reduce pain, such as non-narcotic analgesics, such as tricyclic antidepressant. imipramine, and anticonvulsants such as pregabalin or Lyrica, gabapentin or Neurontin, carbamazepine or Tegretol, and this provides pain relief for them. Some non-pharmacological pain relief that can be done is transcutaneous electrical nerve stimulation, and that's like a TENS unit. There's also elastic compression stockings, increasing their sodium, using fludrocortisone, which increases their fluid volume, or an antihypotensive agent such as midodrine. This can help reduce their orthostatic hypotension. We can also give small frequent meals with metoclopramide for the relief of symptoms associated with gastroparesis. We can do antibiotic therapy, increase oral fluid intake, urinating every 3 hours to help eliminate UTIs. And there might be some drugs that are currently in the making that could possibly reverse diabetic neuropathies. There's some clinical trials using aldose reductase inhibitors, which will reduce the conversion of high blood glucose to sorbitol, known to damage nerve and renal cells. As far as what we can do as nurses, we want to implement a teaching plan for the management of diabetes and the potential complications that can occur. We want to refer the client for classes with a diabetes educator, extremely stress foot care, and advise the client with peripheral neuropathy to rise slowly from a lying or sitting positions, drink lots of fluids, wear knee-high or thigh-high elastic stockings during waking hours, and emphasize compliance with prescribed medications, and warn the patient to avoid taking more than the recommended doses of analgesics. For digestive problems, we can tell them that consuming a large volume of food or at any one sitting and eating fatty foods will actually delay their stomach emptying. And we can also refer those with erectile dysfunction to a urologist. Diabetic nephropathy is the progressive decrease in renal function that will occur with diabetes mellitus. Patients with type 1 diabetes are more likely to develop diabetic nephropathy, but there are people with type 2 that also develop this as well. Now, nephropathy is a consequence of the glomerular deterioration, and this results in an impaired filtration of blood during urine formation. So there are 5 stages of nephropathy, and they're each characterized by a successive progression of renal dysfunction. Essentially, what happens is the glomeruli will excrete serum proteins, especially albumin, and they lose their ability to excrete nitrogen waste products. Poor glucose control contributes to the onset of nephropathy, and although hypertension is an eventual consequence of diabetic nephropathy, when it occurs in pre-diabetic or pre-nephrotic states, it accelerates the onset and progression of kidney damage. So let's talk about the stages of diabetic nephropathy. So in stage 1, some of the characteristics in stage 1 are hyperfiltration and glomerular hypertrophy. So in hyperfiltration, the blood flow through the kidneys is increased. And in glomerular hypertrophy, the kidneys are enlarged. Generally, stage 1 won't happen until about 10 years after their diagnosis of diabetes. In stage 2, the characteristic would be microalbuminuria. And this means that albumin, which is a blood protein, is excreted in small amounts. This will happen about 15 years after the diagnosis of diabetes. Then we have stage 3, which is gross albuminuria, and this is a large amount of albumin that's excreted, and you'll find that their urine will consistently test positive for its presence. Because of this, blood pressure will become elevated and the excretion of nitrogen waste is impaired. This is also within 15 years after the diagnosis of diabetes. Then we have stage 4, which is advanced dysfunction. And this is a severe impairment of glomerular filtration. And you can see excessive proteinuria, hypertension, a rise in BUN and creatinine levels. And this happens about 15 to 20 years after the diagnosis of diabetes. Then we have stage 5, which is the end, and this is end-stage renal failure, and the kidney functions are severely impaired, and most of the time they're going to need dialysis or a kidney transplant. And this happens about 20 to 25 years after the diagnosis of diabetes. Now, in assessing in the early stages, the patient won't really show any kind of obvious signs and symptoms, but eventually you'll start to notice that their hands and their feet are swollen. And this happens because they're losing albumin. Now, albumin, if you remember, it pulls water into the vascular system. If we don't have that much albumin anymore, then where's the fluid going to go, right? Also, you'll find that their blood pressure will increase gradually. They'll complain of being tired and very weak. And we can do any kind of like diagnostics by doing a routine urinalysis or a dip with a chemical strip. And this will detect that they have albumin in their urine. We can also check on their BUN and serum creatinine just to see if it's been elevated. And we'll find that the renal creatinine clearance is also decreased. In managing this, we want to control their blood glucose levels and hypertension because it can prevent or delay the development of diabetic nephropathy. It's recommended that those with diabetes maintain their BP of systolic lower than 140 and their diastolic less than 90. We can manage this with ACE inhibitors such as captopril and angiotensin II receptor antagonists such as losartan, and this can slow the progressive nature of nephropathy. We're also going to want to educate them on reducing dietary protein and strongly recommending to stop smoking if they do. It is our responsibility to monitor their blood glucose and their HbA1c results. We're going to always want to check to see if their urinalysis shows evidence of albuminuria. And we want to provide additional teaching if their blood glucose level is not controlled. We can provide them with smoking cessation programs and go over their medication regimen and educate them on their antihypertensive drugs and dietary measures in order to prevent complications from vascular disease. So retinopathy just means any kind of changes in the retina. But when we're talking about diabetic retinopathy, we're talking about changes in the retina that are experienced by those with diabetes. Now, diabetic retinopathy doesn't usually develop until about 10 or more years after their onset of diabetes. But the earlier the retinopathy develops, the more likely it is that their vision will become rapidly deteriorate. Now, diabetic retinopathy is usually a consequence of inadequately controlled blood glucose levels, which will cause vascular changes in their retina. Now, there are two types of diabetic retinopathy. There's non-proliferative, which is the mild manifestation, and then there's proliferative, which is the most severe form, and this can lead to blindness. So in non-proliferative retinopathy, which is the milder one, there are these microaneurysms, which are these kind of like outpouchings in the capillaries in the retina, and they develop from high vascular pressure and compromised circulation. Now, because the blood flow isn't moving, it interferes with transferring substances between the retina and the blood vessels. And what happens is because the retinal cells are deprived, they end up swelling. In the more advanced severe form of the proliferative form, damaged blood vessels are replaced with new ones, but the new ones again, they're on the surface of the retina. But the new ones, they're fragile. So what happens is they rupture and they leak blood into the vitreous fluid in the posterior portion of the eye. And because of that, there's this scar tissue that forms. And when we get that scar tissue, it'll alter the shape of the retina, which will cause distorted vision. It'll pull out our retina and increase the potential for retinal detachment. When we are assessing somebody that we might think has non-proliferative or proliferative retinopathy, we have to realize that they might not have had any experiences of visual changes for quite some time. It comes kind of gradually. So when the symptoms do occur, they'll usually complain of blurred vision, no vision in spotty areas, or seeing kind of like debris floating in their visual field. They'll complain about visual acuity being diminished. And when we do their eye examination, it will show that they have swelling near the macula of the eye. So in diagnosing this, we can do fluorescent angiography, which will document changes in the retinal blood vessels in kind of like a photograph. So in order to medically manage somebody with diabetic retinopathy, we want to make sure first that they are referred to an ophthalmologist, because they need to be evaluated within 3 to 5 years after diagnosis. Now, if there's no evidence of retinopathy for one or more eye exams, this can be repeated every 2 years. If there is evidence of retinal vessel changes, we can give an ACE inhibitor such as lisinopril. And what lisinopril does is it dilates the retinal blood vessels and improves the blood flow. If there's a hemorrhage that has occurred already in the vitreous, what some of the doctors will do is they'll kind of let it resolve on its own, but that can take up to 18 months. A quicker way to handle that is to seal the leaking or newly forming blood vessels with laser photocoagulation. We can also do a vitrectomy, which is removing the bloodied vitreous, and that what that'll do is it'll improve their clarity of vision. So after we have managed it with medicine, we want to encourage those with diabetes to follow their regimen. We want to make sure they are controlling their glucose, give them education about complications associated with diabetes, encourage eye examinations, and with their medications, it is our responsibility to explain their purpose, any kind of techniques for self-administration, side effects they may have, and any symptoms that they need to report back to us. Vascular disturbances affect many tissues and organs. In patients with diabetes, however, the arteries and arterioles are more susceptible to accelerated atherosclerotic and arteriosclerotic changes than in somebody without diabetes. So a consistent finding in those with diabetes is that their arterial walls are very thick. This also means that there is a more of an incidence of coronary artery disease that is increased in those with diabetes. One possible explanation for obesity in patients with diabetes is that the brain may be insensitive to leptin, and this is a chemical that signals satiation. Now, if there's a lack of response to leptin, this will promote overeating, which will then contribute to hyperlipidemia. So, in assessing vascular disturbances, peripheral vascular changes are one of the most common complications when we associate with diabetes. Because of a decreased blood supply, the extremities tend to be very pale and cool, and we can get leg cramps. They can also get gangrene, which is tissue death, because blood supply to the extremities they're diminished. Sometimes uncontrolled infection will lead to skin ulcers. Those with diabetes are more likely to develop chest discomfort because the coronary arteries are affected. Myocardial infarction, so heart attacks, can occur at a much earlier age than somebody that's non-diabetic. And hyperlipidemia and elevated triglyceride levels correlate with the predisposition to atherosclerosis. So in diagnosing, we can do laboratory tests, but we can also do angiography and Doppler ultrasonic flow studies because this can indicate peripheral vascular disease. So in managing vascular disturbances, atherosclerosis is managed with lipid-lowering measures, so low-fat diet, exercise, medications. We can also give vasodilators because this combats the effects of arteriosclerosis. We can give aspirin, which reduces platelet aggregation. Smoking cessation is advised. We want to make sure we are monitoring their skin. Any kind of impaired skin is managed with aggressive measures to promote healing. So uncontrolled gangrene of the extremities can actually result in amputation. So we have to very much pay attention to their skin. Generally, in those with diabetes, the lower extremities tend to be the most involved as far as uncontrolled gangrene and needing amputations. We also have to remember that stress is a really big factor in those with diabetes. So any type of surgery or hospitalization is actually a very enormous stressor. The glucose levels of the patient with diabetes increase, and then there is a increased demand for insulin. So again, we have to make sure we monitor their blood glucose levels by administering rapid-acting or short-acting insulin before meals and at bedtime. In managing this as a nurse, we are geared toward the type of vascular disturbance and the signs and symptoms the client experiences.